Pharmacist Joseph Eno. Joseph Eno, can you kindly unmute and give us the opening prayers?
Enter. 250. 250. 250.
Hello, please, can you all mute your phones? Yeah, so good evening. I would just like Pharmacist Eno to give us the opening prayers in the absence of Pharmacist Suleiman Ademola. Please, Pharmacist Eno, if you're on the call, can you kindly give us the opening prayers so that we can begin?
Good evening.
Yeah, good evening.
Okay, let's pray. Our God, we thank you this evening for gathering us here. Thank you for all what you've done for us throughout the day and for giving us a night out this evening to study. May everything we are going to study this evening be to your own glory. May we understand everything. Guide the teachers, guide the lecturers that are going to take us. We ask all this in Jesus' name.
Amen.
Amen.
Okay, thank you so much, Ma, for the opening prayers. And I would like to use this opportunity to welcome each and every one of us this evening for sparing out time out of our busy schedules to be a part of the meeting this evening. This is a special edition of the Clinical Pharmacists Association of Nigeria weekly clinical meeting, which is being held in conjunction with the Infectious Diseases Pharmacists Association of Nigeria, a specialty group of the IDPaN. And I would like to first begin by introducing to all those on the platform. I'm Pharmacist Tangan Zugumnan Bitrus, anchoring and moderating the session this evening. I work at the Federal Teaching Hospital, Gombe. So I would like to take this time to acknowledge the presence of each and every one of us that is on the group this evening, both infectious disease pharmacists present and all other persons from the different specialty groups of IDPaN. So I will begin by acknowledging the presence of all the ESCOs of IDPaN, which is ably led by our chairman, Dr. Joseph Madu. I don't know if he's currently on the call. Then I would move on to acknowledge the presence of all the chairmen and ESCOs of the IDPaN group present. Then all the state coordinators and the secretaries of the different states that are present on this call. I'd like to acknowledge your presence. Also, following up, would like to acknowledge all the fellows of the West African Postgraduate College of Pharmacists and the Pharmaceutical Society of Nigeria. And then to also acknowledge the presence of all the directors of pharmaceutical services from the different states and the head of departments of the different pharmacy departments present, all the members of the academic committee. Your presence is also acknowledged. Then all our final year students from the different pharmacy faculties and members of PANS, all are duly acknowledged this evening. So ladies and gentlemen, we are grateful to God for this great opportunity we have again to partake in the special edition of this IDPaN weekly meeting that is being held today. As I had said earlier, the meeting is done in conjunction with the infectious diseases specialty arm of IDPaN. which is ably led by our DEX officers, Dr. Isa and pharmacist Nasara. So we are so much grateful for this opportunity and the opportunity given personally to me to moderate and lead us as we look into the discussions for tonight. So I believe that our anchor speaker is on the call. So I would like to just take this brief time to give us an introduction of our speaker, who is Dr. Mary Richard Akpan, a senior lecturer with the Department of Clinical Pharmacy and Biopharmacy in the University of Uyo. It's worthy of note that she has her research focus on antimicrobial stewardship and public health pharmacy, and also looking through her array of literatures and papers, she has works on implementation of antimicrobial stewardship programs in African countries, a systematic review actually, and then a review of the quality measures for assessing the impact of antimicrobial stewardship in hospitals amidst the several other papers that she has published. So without much ado, I would like to give the floor to our speaker for tonight. So Ma, you are warmly welcome. You can go ahead to lead us in these discussions. And I would like to ask that as many that have questions, you can note them and you can send some on the chat box, which will be duly noted and attended to after the presentation. So Ma, you are welcome to take over.
You need to unmute yourself. The monitor, the speaker. Unmute, please. You need to unmute yourself, please. Yeah, muted. Unmute.
Yes, Ma, so you can go ahead. I saw that you unmuted yourself.
Can everyone hear me now? I have unmuted myself.
Yes, Ma, we are hearing you.
Okay. All right. So for the people who didn't hear me, I was trying to say that I consider this a very rare privilege, and I feel very honored to be given this opportunity to anchor this session this evening. That I don't take this opportunity for granted at all. And I believe that we are all going to be learning. And it's my prayer that every one of us will have what to tools, will be better equipped to deliver, service to our different workstations when it concerns management of sepsis. At the end of this meeting today, I want to start. I don't know if I've tried to share my slides. I don't know if we are able to view my slides from where you are. Can you confirm if you can view the slides, please? You can at least you can see the slides which I have shared.
Slideshow. Go to slideshow to make it bigger. Go to slideshow to make it bigger.
Okay. Okay. Yeah. Okay. Can we see my slide now?
Yes. Better now.
Yes, ma'am.
Okay. All right. Yeah, the PDF. Yeah, so the PDF, I sent the PDF earlier to the lead of this specialty unit. Okay, so management of sepsis from the clinical pharmacy perspective. So we have some objective that we look forward to achieve at the end of this evening. So we will at the end of this session, we should be able to compare and contrast the definition of sepsis and other related terms. That's because sepsis has undergone, a lot of revision of its definition over time. We should be able to identify the risk factors for sepsis and the organisms that are most associated with sepsis and septic shock. We should be able to discuss the pathophysiology of sepsis as it relates to systemic inflammation and coagulation. And we should be able to identify the symptoms of sepsis and evaluate diagnostic and laboratory tests that can help in, treatment and monitoring of sepsis. We should be able in our practice to identify the complications of sepsis and how these complications impact on patient outcomes. And we should be able to collaborate with other healthcare professionals in treatment and management of sepsis and delivering performance bundle as it relates to management of sepsis. So like I said, over the years, sepsis has undergone, revision of its definition. But in your practices, I mean, if a patient walks up to you in your community practice, oh, I heard this word sepsis in the hospital the last time I was there. So what is sepsis? So a layman, sepsis is a systemic inflammation that is due to a suspected infection or a known infection that can result in damage of certain organs and organ failure and then subsequently death. So prior to 2016, where the third consensus for the international consensus on definition of sepsis was published, sepsis was, viewed as a continuum of, progressive physiologic decline that begins first with an infection that can be caused by either a bacteria or a fungi. That infection now triggers a systemic inflammatory response. And that can be due to, an infectious or a non-infectious agent. And the criteria for knowing if a patient, has a systemic inflammatory response due to sepsis is you could have hypothermia, that is an elevation in the body temperature, or hypothermia. You could have increased heart rate that is over 90 beats per minute. You could have respiratory rate that is over 20 normal. Usually the normal respiratory rate is 18 breaths per unit to 20. And you could have, white blood cells, that is leukocytosis, that's the range of greater than or equal to 12,000 cells per minute. So that is what these are the manifestations. So if you have one or two or more of these, parameters elevated, either hypothermia, or increased heart rate, or tachypnea, that is increased respiratory rate, you can say that a systemic inflammatory response syndrome has set in. All right, so from an infection to systemic inflammatory response syndrome to sepsis. So sepsis, following this continuum, was defined as systemic inflammatory response syndrome plus a probable or a documented infection. And then you also have that which can progress to severe sepsis, where you have sepsis plus one or more organ dysfunction or a hypoperfusion. So hypoperfusion abnormality will include something like lactic acidosis, oliguria, alteration in mental states, and then that progresses to septic shock, which is sepsis in the presence of persistent hypotension, even when there is an effort to resuscitate the patient. So, I said the definition has undergone a lot of revision over the years. So, some, critical care experts, consider that this continuum, looking at sepsis as a continuum, is misleading and is confusing because the criteria, the SIRS criteria, is not specific enough to define sepsis. Neither is it sensitive enough. and that to use the term severe sepsis is misleading. So because of that, Association of Critical Care Experts across the Western world, Europe and Americans convened a conference, and that led to the publication of the third international consensus on definition of sepsis, which is popularly called sepsis theory, which defines sepsis as a life-threatening organ dysfunction caused by a dysregulated, host response to an infection. So how do you define that there is sequential organ failure assessment that is used? We're going to see that in a bit, that is used. So when you look at, if you use this tool to assess sepsis, the scores that you have, depending on what organ this tool is assessing, any score that you have that is greater and equal to 2 points, you can say that there is organ dysfunction is beginning to set in for that particular organ that this tool accesses. So sepsis 3 defines septic shock as a subset of sepsis, which has more profound circulatory, cellular and metabolic abnormalities with greater risk of mortality than sepsis alone. Okay, and with the sepsis 3 definition of septic shock, so a patient that has progressed to septic shock will be identified if that patient has a mean arterial blood pressure of greater than or equal to 65, or a lactate level that is greater than 2 millimole per liter. So this third, international consensus definition of sepsis focuses on, emphasizes 3 things about sepsis. One, that when sepsis occurs, the body loses its ability to regulate how inflammatory mediators are released. And because of that, there is a potential for lethality, and there is the risk of organ dysfunction, which requires prompt treatment. So that's what the third definition of the sepsis 3 definition of sepsis try to, point out. So with that, we can compare and contrast the definition of sepsis from the very first sepsis following a continuum of physiologic decline to sepsis, and then compare it with this third sepsis 3 definition that was published in 2016. There are a number of factors that can predispose a patient to, to sepsis. We already know that the extreme ages, the very young and the very old, are prone to certain diseases, handling of drugs. The same thing applies with sepsis. So the very young and the very old stand a greater risk of, developing sepsis if they contract infection, either by bacteria or fungi or virus. Patients that have comorbid conditions such as, cancer, HIV, and, in the last how many years, COVID, have greater risk of developing sepsis if they are infected with any of these pathogens. Patients on immunosuppressants, those that are exposed to invasive procedures, transplant, organ, liver, kidney, burns, trauma, if there is an anatomical obstruction, such as intestinal obstruction or urethral obstruction, or even intestinal ulceration, as in case of maybe peptic ulcer or gastric ulcer patients that are alcoholics, and the male gender is associated with a higher risk of sepsis, although the gender difference with respect to developing sepsis is narrowing when you compare male to female. All right, there are some organisms that you're likely going to see if a patient comes down with sepsis. That include the gram-positive, which will account for larger cases of, cases of sepsis that you will encounter, specifically Staphylococcus aureus, Streptococcus pneumoniae, and the Enterococcus species. amongst the gram-negative E. coli comes into question, Klebsiella, Pseudomonas aeruginosa. You could also have a situation where sepsis results from polymicrobial infection, and you could have fungi, especially the Candida albicans and the Cryptococcus that cause that result in sepsis. In about 70% of sepsis, you will find you might not see a specific or just one organism being isolated. Now, there are some organs or systems that, are prone to, leading to sepsis if that particular organ or system is infected. So respiratory tract tops the list. So if an infection of the respiratory tract, up to 40 to 42% will result in sepsis. If there is an intra-abdominal infection, up to 34% of such infections will result in sepsis, and UTI is the very least, with 11 to 15% if you have urinary tract infection that will result in sepsis. So what happens that will result in sepsis? So you have this cascade that starts with, like we explained from the continuum of sepsis that we look at from the former definition of sepsis following a continuum. So you have an organism, a pathogen, which can be a bacteria, a fungi, a virus, like the SARS-CoV-2 virus, that that a patient comes in contact with through any of these routes that we just looked at. Okay, that particular organism now activates the inflammatory system, the immune systems in the epithelial cells, the macrophages that produce the inflammatory loads of the inflammatory mediators, what you will call a cytokine storm. So macrophages, endothelial cells will release inflammatory cytokines that could be anti-inflammatory or pro-inflammatory. We're going to see some of them as we go. So these cytokine storms, so to say, will result in a loss of the ability of the body to control itself, and that will result in organ dysfunction, depending on what organ is, it was infected. And of course, by the time you have this, widespread release of inflammatory mediators, so many other organs are going to be affected, as we will see shortly. Okay, so if a patient, is infected with gram-negative, bacteria, on the outer cell wall, the gram-negative bacteria is an endotoxin that is called lipopolysaccharide. That is released when the bacteria is lysed or broken down. So this particular endotoxin forms a complex with a protein that is produced by the body, lipopolysaccharide binding protein. There is also another toxin. These are just the virulent factors that predispose a patient to progress to sepsis if is affected with gram-negative bacteria. There is another virulent factor on the gram-negative bacteria that is called lipid A. This is very immunoreactive. So this will activate the macrophages via the CD14 receptors. So when you have this complex of the endotoxin, the lipopolysaccharide endotoxin produced by the bacteria, all the lipid A produced by the bacteria, forming a complex with this endogenous lipopolysaccharide binding protein. This complex is what elicits, the inflammatory cascade that releases all the cytokines, the interleukins, the tumor necrosis factor that will result in sepsis. So with regards to gram-positive bacteria, the virulent factor there is the peptidoglycan that is found on the surface of the cell wall that also exhibits, immunoreactive activity. By the time this combines with macrophages although the intensity with respect to gram-negative and gram-positive bacteria is less. So you have widespread release of inflammatory mediators that will result in sepsis and septic shock. So this interaction between pro-inflammatory and the anti-inflammatory mediators is involved in the pathogenesis of sepsis. And some of the pro-inflammatory mediators, like I mentioned, tumor necrosis factor, interleukin 1, interleukin 6, 8, and then you have the other cytokines that are also involved. So while the body, tries to fight the infection by releasing these cytokines, there are also the anti-inflammatory mediators that aims to downregulate, to try to regulate the hemostasis by inhibiting, reducing the rate of inflammation. And they include interleukin receptor antagonists, interleukin 4, interleukin 10. So this tries to inhibit the production of the pro-inflammatory cytokines that we see. So when you have this balance between the pro-inflammatory and the anti-inflammatory mechanism that determines the systemic inflammation and how the organs are affected, and that may result in death. Sepsis also involves the coagulation system, because as the pro-inflammatory mechanism promotes sepsis, it also affects the pro-coagulant and the anti-fibrolytic system. So coagulation contributes or aggravates sepsis by reducing, fibrillosis and reducing anticoagulant system, and contribute to further inflammation. There is this particular protein, the activated C proteins, that help us to, inhibit inflammation. Levels of activated C proteins are very high in septic patients. So when you have depletion of anticoagulant and fibrolytic factors, it contributes to microvascular deposition, and that could result in organ dysfunction. So sepsis is associated with a number of complications, one of which is that you could have, because the coagulation system is involved, you could have disseminated intravascular coagulation, and that can result in acute renal failure, hepatic failure, and pulmonary failure. You could also have, acute respiratory stress syndrome because of massive release of platelets and neutrophils. You could have hemodynamic system effects that will include, because there is over stimulation of the sympathetic system, that will result in an increased cardiac output, low systemic vascular resistance and hypertension. Sepsis can result in acute kidney failure and septic shock. And there are about 4 types of septic shock. You could have hypovolemic septic shock, cardiogenic or obstructive, or vasodilatory and distributive septic shock. The septic shock that result from sepsis is classified under the vasodilatory and distributory shock, that is characterized by decreased hypertension, an increase in heart rate, and a decrease in systemic vascular resistance, and then pulmonary capillary pressure. So how do we identify sepsis in our practice? Don't forget, sepsis is a medical emergency. So if you're a community pharmacy and a patient comes to you with these signs, you don't hesitate. You quickly refer the patient to where he's going to get the appropriate care, which we are going to see in a bit. All right, so depending on the host, response to the infection and other risk factors, which we saw, like age, is it a very young patient or an old patient? Does this patient have other comorbid conditions? The initial signs and symptoms of sepsis could include myalgia, fever, could be, hypothermia or hyperthermia. The patient could present with chills, tachycardia, tachypnea, alteration in mental state. If these are not controlled, it can progress to arterial hypertension, oliguria, where very little urine, little or no urine is produced, hyperventilation, where the patient is, just gasping to breathe. There could be alteration in the glucose metabolism, and there could be metabolic acidosis that is caused by impaired glycolysis. All right, so these are the signs that as pharmacists we need to look out for in our practice. You're in the community, the patient comes present with alteration, and you don't keep that patient, you send the patient to where he will get the care that he needs. So how is sepsis diagnosed? Of course, there is need to take appropriate history, physical examination to identify any possible site of infection. Has the patient had prior antibiotic use? And then blood sample needs to be taken, at least 2 types of blood sample to avoid contamination. And that should be done before antibiotic is administered, because one of the performance bundle that needs to be carried out once a patient is diagnosed or with sepsis is that there has to be prompt antibiotic therapy. Cultures of urine, depending on where the site of infection is, the cerebrospinal fluid, urine, wound swab can be taken for culture. And then there is need to be a battery of laboratory tests that needs to be done to check coagulation factors, check the blood cells with differentials, measure the lactate level, check for arterial blood gas. Depending on the organ involved, there might be need to do some radiographic imaging. Now, there is a particular biomarker of inflammation that could be measured too, that is procalcitonin. Although there is controversy whether it should be used, in fact, current guidelines does not recommend that you measure procalcitonin. But if that is done, where the facilities are there for procalcitonin, because it's a core with C-reactive protein, these are core biomarkers that tells you there is an inflammatory process is going on. So the value of procalcitonin can be used, or the way the facilities are available to measure can be used to either discontinue antibiotics. Now, because from the sepsis 3 definition of sepsis is a life-threatening situation. Sometimes you might not have all these laboratories, investigations handy to actually, recognize, oh, this patient is septic. Because of that, there are screening tools that have been developed to help, healthcare professionals, recognize sepsis as soon as it presents itself, and that will then so that the management can be informed. So the sepsis, the SIRS criteria that we use is one tool that can be used. So you can look at the patient's temperature. Is the patient hypothermic? Is the patient hyperthermic? You can look at is the patient tachypneic? Is the respiratory rate more than 20, breaths per minute? Is the heart rate more than 90 beats per minute? So those SIRS criteria can be used to screen, to recognize sepsis. There is this other tool, the sequential organ failure assessment, to the software that we saw earlier on, that can also be used. There is the National Early Warning Score that measures parameters such as oxygen saturation, respiratory rate, systolic blood pressure, pulse rate, level of consciousness, all that can be used to recognize, because the key to survival in sepsis is early recognition. If the condition is recognized early, chances of saving the life of the patient increase. But among these tools that have been developed to, screen for sepsis, the most commonly used tool is the software tool. So software tool. Can everybody still hear me? I'm hearing some rumblings. Okay, I hope you're still hearing me.
We
So
are hearing
Yes,
among
you.
these
ma'am.
We are
two,
hearing you.
okay,
Yes,
so
ma'am. We are
okay,
hearing you.
thank you. Thank you. Yeah, so among these two that have been developed to screen for sepsis, the most common used one is the SOFA. So SOFA looks at the pulmonary system, it looks at the coagulation system, it looks at the cardiovascular, it looks at neurologically, it looks at the renal system. So when the figures are plugged into these two scores, of course the SOFA score ranges from 0 to 4 for each system. So a patient that falls, like we saw, any score greater than or equal to 2 tells you that this patient has a high risk of having an organ failure. And that could help to escalate the care from wherever the care, assuming the patient was admitted through the emergency unit. If the score changes from maybe if it was 1 or 1.5, and then it now goes to 2, it signals that this patient needs to be moved from the emergency unit to the ICU. So this scoring system helps to, help with the improved prognosis of patients. But the SOFA, as it is, has a drawback because, as we're going to see, all these organs, you need to take blood sample to be able to have the number of thrombocytopenias, thrombos, the platelet. You need to do a complete blood count to know the number of white blood cells and then the other differentials. So, and with respect to creatinine, of course, you need to look for the blood level, the creatinine blood level. So that is the drawback that's associated with SOFA as it is. So because of that, the quick SOFA was developed that just look at 3 elements that includes respiratory rate. Is the patient, so by the time you check the patient's respiratory rate, is it more than 22 breaths per minute? Is there alteration in the mental status of the patient? Is the patient confused? The patient was, conscious of himself, then suddenly start speaking incoherently and forgetting where he or she is. Is the systolic blood pressure more than 100 millimeters of mercury? So this is what quick SOFA measures. So a doctor, a pharmacist can quickly, just check this, and with that, escalate the care of such a patient. And we have said that if the score, whether it is quick SOFA you're using to screen the patient or you're using SOFA to screen the patient when you have had all your blood work come in, if your score for each system is more than 2 or is 2 or more than 2, you should be vigilant and think of escalating the care of the patient. Although the current guidelines, as we see, does not, recommend using quick SOFA alone. If you're considering using quick SOFA, you should also use the other tools to compare the values that you have, to compare so that it can give you a clear picture of where the patient is and what kind of care needs to be initiated. So the table that you have there, shows you the system that the SOFA assesses: respiratory, saturated oxygen pressure, coagulation. In the liver, we look at bilirubin. Cardiovascular system will look at the mean arterial blood pressure. The CNS will look at the level of consciousness using the Glasgow Coma score. Renal system will check for creatinine, and then the urine output is the oliguria. And then you have the various levels, the various scores that stands for each. So 0, 1, 2, 3, you're crossing from 1, 1.5, and you are heading to 2. You should think of escalating the care for the patient. All right, so what's the goal of treatment of sepsis? Because of the life-threatening nature of sepsis, you want to, make a timely diagnosis and identify. You want to quickly, eliminate the source of the infection. For instance, if there is cellulitis, there could be incision and draining. Okay, you want to initiate, aggressive antimicrobial therapy, depending on, what kind of organisms you're dealing with and what sites of infection what site the infection took place. You want to interrupt the scene that the patient does not progress to septic shock, which is a subset of sepsis that we saw earlier on. You want to ensure that there are no organs failure, that the patient's kidney does not pack up, the patient's lungs does not pack up. You also want to, look at other, especially if the patient has been moved, say, from emergency to ICU, where the patient is completely immobilized. You want to look out for stress ulcer. You want to try to prevent venous thromboembolism. You want to ensure that because the patient at this time, you say alteration in mental state, the patient might not be conscious. You want to ensure that the patient's nutritional needs are met. So these are the goals of therapy in management of sepsis. Now, because we are pharmacists and we are looking at sepsis from the pharmacist, there is a patient care process that a pharmacist can initiate in collaboration with other healthcare workers. And that patient care process involves some steps that you could put acronym as CAPIME, CAPIME, to achieve those treatment goals that we just looked at. Where C stands for collect, that means you have to collect the patient's characteristics and all the history of the patient, medical, social, objective data that can help you, recognize that this is, sepsis. You want to assess, and in your assessment of the patient or screen, you can assess, or you can say assess or screen. You want to screen the patient. Does the patient have any alteration in his mental status? Is any of the SIR, parameters present? Is the patient, what is the systolic blood pressure like? Is there lactic acidosis, that may result from accumulation of lactate in the blood? You should also, evaluate the patient for risk of multi-drug resistance. For instance, has the patient taken antibiotic? What was the spectrum of the antibiotic that was taken in the last 2 weeks or a month? Is the patient immunosuppressed, HIV, on cancer, or that will predispose the patient to developing a fungal infection? When you have collect your data and then you make your assessment or your screening, you now plan to initiate, because with sepsis, available literature says that if you deliver a performance bundle, which we're going to see in a bit, within 1 hour, your chances of reducing mortality is very high. If a performance bundle, which we're going to see, is initiated within the first 1 hour of recognition of sepsis. So plan that will include, initiating the 1 hour bundle. And if your 1 hour bundle is not giving you the results that you want, you can now escalate it by administering intravenous hydrocortisone. You don't administer intravenous hydrocortisone just as, oh, maybe you've screened the patient, this patient is a septic patient. No, that's not the first line. All right. And then you can escalate it depending on how the patient is responding to the 1 hour bundle. You can now implement, that is, how do you manage, select your, vasopressor? How do you plan to, implement? Because with sepsis, you initiate broad spectrum intravenous antibiotic. The good thing is that this group is the antibiotic stewardship group. We know that how long you use IV antibiotics increases your risk of developing resistance for that particular antibiotic. So part of your implementation is include assessing for opportunity to de-escalate, the antimicrobial therapy. And if for any reason there was need to initiate hydrocortisone because of the effects on adrenal sufficiency, of course, and you know that because of that risk, hydrocortisone is steroid. Like hydrocortisone is not stopped abruptly. You need to design a program to, taper the dosage and then coordinate the treatment. If the patient is now stable, in the ICU, collaborate and coordinate how the patient will transit from the ICU to the ward. And then the M&E is monitoring and evaluation. So you monitor, has the infection resolved? Is lactate level normalized now? Is the mean arterial blood pressure what it should be? Do we need to consider if vasopressor was used? Do we need to consider, do we need to continue or discontinue? And amongst the drugs that the patient is giving, also need to monitor for side effects. So for the capping, you see that the first two, the pharmacist can do that all by himself just by looking at the patient's case note and maybe interacting with the patient or the caregiver at the time to get those information. But the P and the I and the M and the E has to be done in collaboration with other healthcare professionals. So this surviving sepsis, there has been this surviving sepsis guideline that has been published, and it's undergone a lot of revisions over the years. The very current, guideline was published in 2016, the surviving sepsis guideline, which outlines a bundled approach to the management of sepsis. So first of on the list, once sepsis is recognized, a patient is recognized to have sepsis from what we have learned so far, either through using the SIRS criteria or using the SOFA score, whatever screening tool you decide to use to screen the patient. First line treatment is to initiate resuscitation, because don't forget, one of the key signs and symptoms of sepsis is that there is hypotension. So you want to bring back the blood pressure to normal. You want to restore the mean arterial blood pressure. So that is done by intravenous fluid infusion of crystalloids. That can be normal saline, Ringer's lactate, plasma light. The current guideline recommends that you use a balanced electrolyte. And because of the risk of normal saline resulting in hyperchlorinemia, so Ringer's lactate or the plasma light is recommended. Colloid can also be used, such as albumin may also be used in case of a patient that you run 30 mils per kilogram body weight of any of these crystalloids, and there is still hypotension. Colloid like albumin can be administered. The next thing is to initiate broad spectrum antibiotics within the first hour of recognition of sepsis. So that is part of the 1 hour bundle. And depending on the site of the infection and the source of the causative agent. So there is this table that you have there that tells you what kind of antibiotic you should go for to target after you have defined the infection site. Like we saw, respiratory tract infection will likely result in sepsis, followed by intra-abdominal, then followed by a urinary tract infection. So if the route of infection is urinary tract and that infection was acquired in the community, your first line antibiotic will be ceftriaxone or ciprofloxacin or levo. If it is hospital acquired, that will be ciprofloxacin or levo or ceftazidime. If it is respiratory tract that is involved, your first line will be levofloxacin if it's from the community, or piperacillin tazobactam if it is from the hospital, is acquired in the hospital. If the route of the infection is intra-abdominal, entapinum will be your drug of choice, your first line, or cipro or levo if it is acquired in the community. But if it is in the hospital, your first line would be piperacillin tazobactam or carbapenem. If it is soft tissue infection. And so your first line, if it is a community infection, will be vancomycin or linezolid or daptomycin. And then you have the other choices. Okay. So if you look at this table, you see that these antibiotics are very broad spectrum antibiotics with potential to develop resistance. And if you look at this table again, I don't know how many of us have heard of our classification of antibiotics. So recently, as early as 2019, WHO, the team, the expert committee that develops, the WHO model essential medicine list, classify antibiotics into three groups. So you have the access group, you have the watch group, you have the reserve group. And these antibiotics are so classified because of their propensity for bacteria to develop resistance to them. So this class of antibiotics, that will, if you have not heard of our classification, so that's your homework today. You're going to look at it because these antibiotics all come from the watch group. The watch group antibiotics have higher risk of developing resistance, bacteria developing resistance to them. And the reserve group have even a higher resistance potential than the access because they are very broad spectrum. Watch group rather, and then the access group have narrow spectrum and their resistance potential is very low. So WHO recommends that kind of access group. So 60% of all antibiotics prescribed, whether in the outpatient or in the inpatient setting, should come from the access group. So your assignment for tonight is that you will look for our classification and try to group these antibiotics. Okay, so daptomycin is in what group? Is it access? Is it watch? Is it reserve? So the reserve group are the last resort that should only be prescribed in situations that you have multi-drug resistance. All right, so I've given you one assignment there. Okay, so normally with sepsis, the duration of antibiotic treatment should be 7 to 14 days. But because we're talking about antibiotic stewardship now, if it's a patient is on antibiotics, like IV antibiotics for 7 to 10 days, that's pretty long. That patient, before he leaves the hospital, is likely going to develop resistance for that particular antibiotic that has been used for this long. So there is need to evaluate, that is why it's important before antibiotic is initiated, blood sample should be collected. In fact, where rapid diagnostic is available within 30 minutes to 1 hour, you will have your result and then you will be able to de-escalate. So you can de-escalation simply means that you're changing from the intravenous to oral, or you are changing from a broad spectrum antibiotic to a narrow spectrum antibiotic based on your culture results. So, it is in situations like sepsis that you have Department of Health England developed a tool that could guide pharmacists and doctors to, manage antibiotic. So I don't know how many of us have heard about start smart, then focus. So you start smart in sepsis, you start smart. That means don't withhold antibiotic. Once you make the recognition of sepsis, don't withhold antibiotic. Administer the broad spectrum antibiotic. But before that, obtain blood sample. That is start smart. Then focus. After 48 to 72 hours, assuming you don't have rapid diagnostics, that you could have your culture result within 30 minutes to 1 hour. After 48 hours of placing a patient on intravenous broad spectrum antibiotic, focus based on your culture result to either switch to a a narrow spectrum or switch from oral. So assuming you started with um, IV ceftriaxone, okay? So after 48 hours, depending on what you have, you should be escalate from IV ceftriaxone to say something like sevalaxine, which is narrower than, as a more narrow spectrum than ceftriaxone. So that is, start smart, then focus. And when you focus, if there is resolution, you can take a lot of steps. You can either de-escalate, and that is switch, or you can stop if at the end of the day, the culture didn't grow anything. So there was no isolation of a bacteria. You discontinue the antibiotic so that you don't risk the patient developing resistance. Okay, so there are situations whereby you might consider to use fungi, an empiric antifungal, but that is not recommended except in critically ill patients. And when you're looking at that, you also consider what organism is involved. So if it is, like candida infections, you could think of something like the azoles. And normally the first line is fluconazole. If it's something like aspergillosis that you are suspecting, you can progress to any of the echinocandins. And these are the conditions whereby you can, risk factor for a patient develop. So if the patient has febrile neutropenia for over 47 days, the patient is immunocompromised, the patient is on dialysis, as we will see. So if the patient has had acute kidney injury, which is a complication of sepsis, and is on dialysis, that patient has a high risk of having a fungal infection from Candida species. Okay, if the patient has a major abdominal surgery, or the patient has been on corticosteroid. So these are the conditions that an empiric antifungal can be administered in addition to a broad spectrum antibiotic. Okay, so at what point in the management of sepsis do you introduce a vasopressor? It is only indicated if after initial resuscitation with IV fluids, you still have the systolic blood pressure less than 90 millimeters of mercury, or your inarterial blood pressure lags between 60 and 30 and 65 millimeters of mercury. That is, you have run your crystalloid or your colloid, and this patient is still hypotensive. They will need to initiate, a vasopressor. And the first line agent is normally epinephrine. Other ones like dopamine can be used, but the first line, or epinephrine can be used, but the first line is no epinephrine. So that slide there shows you the hospital-based performance bundle that must be, executed within 1 hour of recognition of sepsis. So number one, they try to measure lactate. What is the lactate level of these patients? And check if it's within 1 hour. Obtain blood for administer a broad spectrum antibiotics, run your infusion at the rate of 30 mils per kilogram per body weight, kilogram body weight for the first 3 hours until you have your hypertension resolve and blood lactate level resolving as well. If you monitor the patient and there is still hypertension, initiate a vasopressor. So these bundles need to be executed within the first 1 hour of recognition of sepsis. Of course, the three major ones are that you obtain blood pressure, administer antibiotic, run your infusions, and monitor for the blood pressure or the NAP. And that will inform the next step, whether you will initiate a vasopressor, and as it continues, whether you will also go up to IV hydrocortisone. So there are some adjunctive therapies that can be used in management of sepsis. Like I mentioned, hydrocortisone is one of it, but that is not indicated except in septic shock patients where the patient has, is persistently hypotensive despite fluid resuscitation. Sometimes you might need to, because part of what you monitor is the glucose level, blood glucose level. So if at the time blood glucose level is monitored and you have, for 2 consecutive testing, you have more than 180 milligrams per DL, then there is need to initiate insulin therapy to normalize the glucose while you continue monitoring. Because sepsis is a medical emergency that is managed most of the time in ICU, where the patient sometimes is put to sleep, okay, to improve ventilation, especially if the patient is on mechanical ventilation and the patient is immobilized, as we're going to see. Sometimes you might need to, paralyze the patient to improve ventilation. So the patient is immobile. So with that, there is a risk of development of venous thromboembolism. So they might be for ICU patients. It is recommended that, low molecular weight heparin is used, or mechanical prophylaxis in situation that, heparin is contraindicated. With ICU patients, they also have a high risk of having stress ulcers, that is gastric ulcerations. So guideline recommends that a proton pump inhibitor or H2 receptor antagonist should be initiated in patients that are in ICU to reduce their risk of developing GIT bleeding. Okay. So there are times that the patient might not be able to breathe on his own, so there might be need for oxygen therapy. And like I mentioned, for patients who have developed a complication, such as the acute respiratory distress syndrome, that the patient now needs, mechanical ventilation, there is need to improve that ventilation by, administering a neuromuscular blocking agent, and rocuronium or verochronium can be used, any of the two, and the other agents in that class can be used. So for patients that have developed AKI, that is acute kidney injury, like we say, one of the complications of sepsis, there might be need to, initiate dialysis, that is renal replacement therapy. And how soon you initiate the renal replacement therapy does not affect the mortality. So whether you want to delay, if you notice signs of AKI, you can initiate therapy immediately, or you can delay the therapy. However the physician chooses to do it, it does not really have much impact on the outcome. Okay. And then, when some people are sick, a lot of things are tried. So there is some school of thoughts that think that sodium bicarbonate therapy can be used, especially if a patient, despite all efforts with resuscitating with IV fluids, and maybe progressing to vasopressor, and maybe progressing to hydrocortisone, if there is still a problem with hypoperfusion, that sodium bicarbonate therapy, those category of patients, they have progressed, they are already now in shock, vasodilatory or distributive shock. They are already at the state of shock. So that sodium bicarbonate therapy can be, administered to reduce how much vasopressor is used. That is not recommended, except there is severe metabolic acidosis, where you have the pH, the blood pH, greater than or equal to 7.2 in the presence of acute kidney injury. There are some school of thoughts that also think that because vitamin C has anti-inflammatory properties, and we have established from the pathophysiology of sepsis that you have a lot of inflammation. in fact, systemic generalized um, inflammation, what you call cytokine storm. You will recall that during the onset of COVID, that there was this cocktail. If you use a combination of vitamin C, zinc, and azithromycin, you can reduce mortality. So some of these things are there, but current guidelines don't support using vitamin C, what is called metabolic resuscitation, that is high dose vitamin C in combination with vitamin B1 thiamine and cortisone. That is not recommended in the current guideline because it's not been shown to either lower mortality in patients with septic shock. So in patients that have progressed from sepsis to septic shock, there is need for, these patients are in ICU, they are not feeding. So there is need to initiate enteral nutrition to, keep their gut working, prevent intestinal permeability, and also slow the inflammatory response. So that is recommended in management of sepsis. So those are the adjunctive therapies that can be initiated based on how the patient responds to the first line 1 hour improvement performance bundle. So what's the prognosis of sepsis? A number of factors can affect whether the patient will come out alive if he has sepsis or he's not going to come out alive. If that infection is caused by a gram-negative bacteria, that is likely going to result in septic shock. And you know that septic shock, from what we have seen so far, is very delicate because the patient is, is persistently hypotensive. If a patient has very fatal conditions, underlying conditions like leukemia, aplastic anemia, has burns of up to 90% of the body surface affected, those kind of patients have poorer prognosis compared to patients with diabetes or, renal insufficiency. If a patient develops acute kidney injury, that patient has a 2 to 3-fold risk of, higher in-hospital mortality. Especially if that patient already has a kidney problem that has progressed to stage 3 compared to those that have no kidney problem. If a patient develops acute respiratory distress syndrome that is so bad that it leads to develop acute kidney injury that is so bad that it needs to be dialyzed, that patient has a higher rate of dying, greater risk of dying than a patient that does not require dialysis. So whichever complication it is, whether it is ARDS or DIC or AKI, patients that have developed one or more complications as a result of sepsis have a higher percentage of death mortality rate as well. If the number of failing organs, maybe the respiratory system fails, followed by renal system, maybe followed by, say, hepatic system, as the number of organ failure increases, the mortality also increases proportionately. So patients that have candidemia are more likely to develop septic shock, and candidemia, sepsis due to candidemia has a higher mortality than sepsis that is caused by a bacteria at the rate of 47 versus 28%. So what we're talking about here largely is management of sepsis in adults. So, but what happens, because from the risk factors, we established that sepsis, the extreme ages, the very young and the very old, have a greater risk of having sepsis. So what happens to management of sepsis in children? So if you want to, have a look at how sepsis is managed in children, you refer to Surviving Sepsis Campaign Guidelines for Management of Sepsis and Septic Shock Associated Organ Dysfunction in Children, and that reference is provided for you. Okay. I don't know how long, Mr. Beatrice didn't tell me how long I needed to talk, but I think I've finished talking, and then you have these resources that you can refer to. Thank you very much for your listening.
Okay, thank you so much, ma'am.
That we've come to the end, and I'll hand over to Mr. Beatrice.
Yes, thank you so much, Ma. We are so much grateful for that well-packaged, enlightening document and presentation. I think we'll still have some few minutes to take questions and answers and contributions
Yes.
that
Yes.
participants will have. So maybe if you would want to ask a question, you want to make a contribution or seek clarification, I would like that we indicate with a raise of hand, or if you would chat it on the box, it will be noted and the speaker will speak on it. At the close of the meeting, we'll take the closing remarks from our DEX officer, and I saw the IDPaN secretary, national secretary online, so maybe the two of them will take closing remarks. But before then, we'll just take time to take some of the questions and answers that we would have. While we do that, I know you've given us a lot of work to look at, I must say. I can remember the assignment you are giving.
Assignments. Yes, assignment on our
yeah.
our
So I believe that participants will be up and down on that. And then I like the CAPIM pharmaceutical care process by the pharmacist.
Yes.
So maybe while we look at that, I can't see anyone indicating so far.
Two people raised their hand. I think two people did raise their hand. I can't see their names. I think Ariola. Oh, I couldn't get that. It just flashed.
Hello, Dr. Joda, my hand is raised.
Yes, okay, Dr. Joda is there. So, Ma, you can go ahead. Just make your submissions. Yes, ma'am.
Okay, thank you. Just a question that has been bothering me since we're here talking about sepsis and antimicrobials. You know, the original school of thought concerning antimicrobials is that your antibiotics, finish your course, finish your course, finish your course. You know, but in these days of antimicrobial stewardship, there has been this new call around you may not need to finish the course of antibiotics because the more antibiotics people use anyway, the more it puts pressure on the antibiotics and contributes to antimicrobial resistance. So I just want to ask if there's really a middle line, or if there's actually a cause for people not finishing the antibiotic course anymore with the current level of knowledge about antimicrobial resistance and stewardship. So that's just my question. It's not directly related to sepsis, but I just wanted to know because I've been really considering it. Thank you.
Okay.
Yes, ma'am. Over to you.
Respond to that, or I take all the question. Okay. Well, for resistance, even though bacteria what is it now? There is a strong link between antibiotic use and the development the development of resistance. In fact, antibiotic use is one of the modifiable risk factors for developing resistance. So you correlate use, how much antibiotic is used, or a patient is exposed to antibiotic, you correlate with the rate of resistance. Yeah, but you know, it depends on whether a patient should complete the antibiotic. Depends on one, what are you treating? Two, what is the spectrum of the antibiotic being prescribed? I mean, if a patient is prescribed something like, okay, so UTI, let's use UTI, urinary tract infection, for example. Current guidelines recommend that, in fact, you don't even start with ciprofloxacin. You start with cotrimoxazole. And if at all, maybe there is a high rate of resistance in your own area, you can progress to ciprofloxacin at a low dose of 250 milligrams for just 3 days. It will clear the UTI caused by E. coli. So if a patient is prescribed for that duration, 3 days, of course, it should be completed that is for acute UTI. But there are instances that the treatment might need to be longer than that. Of course, in such situations, that patients need to complete it if you're treating for a more serious infection. So something like osteomyelitis that you need to treat for months. The patient needs to complete the antibiotic. The downside is that patient may develop resistance to the antibiotic. So it is neither here nor there. Use is associated with risk, and how long the patient uses the antibiotic increases the risk of development. So you're between the devil and the deep blue sea. The patient needs the antibiotic for a long time. Yeah. And the risk is that it will develop antibiotics. So, but is unnecessary use that, something like I just use UTI, that a 3-day course of ciprofloxacin will do the job, and then you put the patient for 1 week, for 10 days. Of course, when the patient discovers that he's not having symptoms, you don't even need to tell him to stop. He will stop by himself. So it's just neither here nor there. But how long the patient uses antibiotics increases the risk of developing resistance. Thank you. I don't know if I have attempted to answer that question. Yes, I can.
Yeah, the answer is really in the wind. Thank you, but I understand your explanation perfectly. Thank you so much. Yeah.
Thank you, ma'am.
Okay, thank you, ma'am. So maybe we'll take the other 3 together. You take them all together. We'll start with is it Dr. Maureen?
Okay.
And then followed by Kingsley, Maureen, and then Dr. Kupa, in that order. So Maureen, over to you, ma, please.
Yes.
Good evening, colleagues.
Yes, good evening, ma'am.
Okay. I just want to appreciate our dear presenter, Dr. Mary IDPaN, for a comprehensive, detailed, I don't know other words to use to qualify the content in her presentation. Thank you so much. For me, as a critical care pharmacist who work in intensive care units, I 100% agree to all you presented. You really showcase the role of pharmacists in critical care units, because basically, as you said, those in the community, once you see that this is real sepsis, you must have to escalate it. Sepsis are managed in intensive care units. Yes. So for us in the ICU, over 50% of our patients admitted always come down with sepsis. And that tells you that there is need for pharmacy to really understand what sepsis is and how to manage sepsis. Very, very important. So from what you said, we have a lot of role to play in managing such patients in the ICU. We need to know when to identify the type of sepsis, the type of antibiotics to use, and make sure there is a septic workup. Because most of the time, they'll just initiate antibiotics, no septic workup. Maybe after 1 week, 2 weeks, fever continue before there's not able to go back to do septic workup. So we are there to initiate antibiotic stewardship and to make sure that they do the right thing based on the guidelines, use of vasopressors.
Yes.
The most important there is to know the right dose, because different doses will give you different effects. So that's the role of pharmacists in such a unit, how to calculate rate of infusion of those vasopressors, managing AKI and the renal dose adjustment at that point, how to read ABGs in case there is a metabolic acidosis, and so even nutrition support. I want to affirm to what you say. We've had cases whereby we continue to give antibiotics up to 3 weeks. Even after the escalation from the septic workup, fever persists until we initiate fluconazole and we get it right. So it's a case that all of us should know. Once you are giving the right antibiotics from the sensitivity test and fever persisted, try antifungal. We've done that and really helping us in our center. So I want to say thank you so much. Really a stray sepsis. God bless you.
Thank you. I appreciate
Okay,
it. Thank you
thank
so
you.
much.
Yeah, Kingsley.
Yes. Hello. Good evening, everyone. And thank you, presenter, for this very elaborate and detailed presentation. I must say I've benefited from it quite a lot. And the question I have is, in the course of your presentation, I don't know if I missed out any part where you mentioned novel approaches to the management of sepsis. Okay, considering that some of these approaches that you mentioned have, been in practice for quite some time. So I'm thinking that as pharmacists, and considering how sensitive, how critical, sepsis is, that there will be novel approach. So specifically, my question is, what is the role of probiotics in the management of sepsis? We know that we have this gut microbiome. We have in as much as we make use of bacteria to get rid of the bad, in as much as we make use of antibiotics to get rid of the bad, bacterial loads, fungal loads in our bodies, we also know that we have good bacteria in a loose sense. And that when we make use of antibiotics, we also get rid of those good bacteria alongside, and they play functional roles in sustaining our immune system. Okay, so in considering new approach to managing sepsis, has it come up at any time, like for our colleagues who are in the in the ICUs, has it come up at any time to look at the role which probiotics would play in managing sepsis? Thank you. That's my question.
Okay, thank you. So, Babalola, you also put in your own question. No, let him come in, then you take the three together.
Okay. So good evening, everyone.
Yeah, evening, ma'am.
Basically, it's what the question that Pharmacist Christopher asked that I wanted to contribute to. So I don't know whether every other person can ask their questions, then my contribution can come in.
Okay, so in that case,
I was actually going to bring that up, because I had a patient, I work in the critical care unit too, and I had a patient that came up with diarrhea, right? And the only way we could actually handle that, because we didn't understand where it was actually coming from. We were just brainstorming that could it have been from the food the patient was having, could it have been, but then the person was on a lot of antibiotics, different, trying to get everything together. And there were a lot of antibiotics. So we took it from the angle of there could have been altered boil flora, and then increase in the risk of Clostridium difficile, and then overgrowth.
Difficile.
Okay, difficile. Now, causing overgrowth. I mean,
yeah.
now, yes, that's causing overgrowth of C. difficile. Now, that I'm bringing up maybe issues of pseudomembranous colitis, you know, and all that. So we looked at all that, and then we decided to put the patients off the antibiotics, and we brought in Floranum. And, you know, we administered Floranum for, in fact, by the time we got to like the second, third day, the patient got better, the diarrhea, you know. And so we gave that for a period of time before we now thought of, reconstituting, starting over antibiotics again, you know, after some time. So there's a tendency for that to happen, for there to be alteration in the bowel flora. And so with that, you can have several other complications coming in. But then, so when you now bring in a probiotic, like in our case, it was Floranum, we were able to restore back the bowel flora, and then the patient got better. The diarrhea actually even stopped, you know, even without introducing, because normally when it happens like that, we're thinking of bringing in metronidazole. We didn't have to even bring in that, and the patient, the diarrhea stopped, you know, before we thought of other things and all that. So we had to advise the doctors that looking at this patient, it looks like there may be some bowel flora alteration, you know, so why don't we try this? And because they also, you know, that we're just trying to brainstorm what could have been happening. Why is this patient they decided to try? But that we brought in that suggestion, and they took the suggestion, and the patient got better. So most times when you have a lot of antibiotics coming in like that, there's a tendency for there to be alteration in the bowel flora, and then growth of, you know, this microorganism that can result into very many other, you know, complications and all that. So, but that's where it comes in. You know, I think, Christopher, I don't know whether I've answered your question. I was actually going to bring that up because we had a case like that, and that's how we handled it. Bringing up a probiotic was how we were able to handle the matter.
Okay.
Yes, thank you very much.
Okay.
Well addressed.
Okay. Can I talk now?
Yes, Ma, you can go ahead now.
Okay. All right. Okay. So Maureen was just, you know, highlighting on the role of the pharmacist in management of sepsis, especially those of us that are in the critical care units, like the ICU. And what I would want to add, in addition to what he said, is that, you know that sepsis also causes those alterations we have, you know, like the increased cardiac output, hypertension, organ failure, you know, kind of affect how our body handles these antibiotics that is administered. So it is important that our critical care pharmacists also look into the pharmacokinetics of those antibiotics that we see. For instance, when you do the fluid resuscitation, you know that you've expanded volume, and there is going to be, you have the volume of distribution of, you know, because there is expanded volume, so volume of distribution of the drug is going to increase. So you might need a higher dose at that time. So these are things that the pharmacy should, you know, have it at the tip of our finger, because when you want to see something wrong, you're a critical patient, you see something wrong, maybe in the way that patient is managed, you need to arm yourself with sufficient information. You know, our doctors can be, sometimes they feel on top of the world. So it's important that we arm ourselves with sufficient information so that by the time we approach them to talk, we know they will see it with us. Okay, so that was just by the way. Mr. Kingsley, probiotic and their role in sepsis management. Well, because the duration of antibiotic for sepsis is 7 to 10 days. In fact, if the patient is in ICU and maybe your cultures haven't come up, you know, that IV duration is going to, you might really, like Mama Lola said, up to 3 weeks in ICU with antibiotics, certainly that patient will come out with a C. difficile infection, which is a side effect of using a broad spectrum antibiotic. Well, it is good to experiment something. Babalala has a practical experience, but medicine is now, the focus now is evidence-based medicine. Probiotic don't have a role in management of diarrhea, okay? But in septic situation, current guidelines does not support, use of probiotic. But you know that some of these guidelines, there is a caveat. There is always a caveat that this guideline does not outright, clinical experience or opinion of the prescribing or the treating physician. So a practical situation like Babalola highlighted, where a patient has been on the antibiotics for 3 weeks and started developing that. Of course, you couldn't suspect any other thing than C. difficile. So it's okay at that point to initiate an intervention, which in that case was administering a probiotic to, to restore the intestinal flora. That's okay. But for now, the very current surviving sepsis guidelines does not make provision for probiotic in management of sepsis. Whether clinical trials in the future will look at that for patients that develop C. difficile diarrhea, well, I believe that will take place. But for now, the current guidelines don't support that. But that doesn't mean that if a patient, develop antibiotic complications, a complication from the use of antibiotic, like has just been highlighted, that it couldn't be used. No, yeah, it can be used. I don't know. I think that was just the main, the only question. The other ones were just contribution to the presentation. The only question was the role of probiotic in management of sepsis, which I have attempted to answer if Mr. Kingsley is satisfied with that.
Okay, thank you so much, Ma. I believe we are very much in line with that, and thank you so much for your time. I would like the audience to appreciate our speaker with an e-clap. Let's just appreciate her for this
Thank you so much.
presentation.
Thank you so
And
much.
I believe we'll get the slides. I believe our DEX officer, at least so that we can go over it over and over. So I would like to...
Don't forget the assignment to look for how where classification is.
Yes, ma'am. Yes, ma'am. So please, let's take note of that, especially I can see the critical care pharmacists and the infectious disease pharmacists that are on call. I think that's very good for us to have it handy in our own practice. So I would like to give opportunity to...
Sorry, can I quickly say something? So in my own pharmacy, my antibiotics are actually displayed according to the AWARE classification.
Oh, that's brilliant.
I know that. So yeah, I really I can appreciate what she's talking about. And in fact, it's even a lot better when you classify them. I mean, when you shelve them according to their AWARE classification. So at each point that you're not missing out on anything. You just have it, I mean, right before your eyes. When you're going for the access, that, okay, do I have all the brands of the access? Do I have the watch? Do I have the reserve? Normally the reserve, we don't normally will put it out like that. We always want it to be at the corner until the patient needs it, and all that. But we must make sure that it's somewhere readily available, that whenever we have the need for it, we can always go for it. It shouldn't be at the reach. I think that's what they said, that it shouldn't be at our reach at all until there's a need for that. So
I don't know what reserve agent that you have, because I just did a study that I discovered that even in a teaching hospital, that we didn't see any antibiotic prescribed from the reserve group.
Okay, so
I was
I had a
tempted to think
patient.
maybe we don't have.
No, we have. I have tigecycline. I have 3 of them. I think tigecycline and poly.
Okay, you have tigecycline.
Yes, I have tigecycline.
You have
I have
tigecycline in your.
yes, and I have three. I can't remember the tigecycline. You know, their names are in a very peculiar. Yeah, I have about 3 of them. I think
tigecycline, yes.
Tigecycline and polymyxin B or polymyxin B. Yes, polymyxin B and one other one. Yes, I can't. The other one I can't place it. Yes, but I have them. Yeah.
Okay, that's okay.
Okay, I think that's a good one. That's a good one for our shelf arrangements, whether in the hospital or the community pharmacies. But just like the presenter is noting, you hardly see some of this in the hospitals, actually, in practical terms. Yeah. So, but then we are so grateful. So please permit me, because of time, let's have the closing remarks from the IDPaN National Secretary, followed by the Infectious Disease Pharmacist Desk Officer. Just appreciate our presenter and give closing remarks on our behalf generally. I don't know if Dr. Motiat is on call. She was around for the presentation. Okay, so if she's not there, Dr. Issa, can you take up the closing remarks, please, sir?
Okay, thank you very much, Pharmacist Beatrice. Let me, on behalf of the IDPaN National Chairman and the members of the Infectious Disease Pharmacists of Nigeria, really appreciate the presenter, Dr. Mary Akpan, for taking her time, despite the cancellation and the scheduling of the presentation at almost 2 to 3 times, but she still accepted to come and do the presentation for us. We thank you immensely. Also, thank you, Pharmacist Beatrice. It has been a very wonderful moderation they have done for this meeting. To everyone that's present from the beginning of the program throughout the session, also thank you very much and do have a wonderful weekend.
Thank you very much, sir. So we are so grateful for that. So we'll just take the closing prayers, and then we trust God to meet again in another special edition of the IDPaN weekly educational presentation. So I don't know if Suleiman Ademola is on call. I had called you previously to pray for us. So if you are on call, can you kindly help us with the closing prayers so that we say good night to all? Okay, doesn't seem to be on call. So what of Mukhtar? Well, it's okay. So Dr. Issa, can you kindly just help us with the closing prayers so that we can call it a night?
Okay, we thank God Almighty for bringing us to the end of such a very wonderful presentation. We pray and beg that the improved knowledge that we've had today will also lead to improved practice towards the advancement of clinical pharmacy practice to our patients all over the world. We ask you this, that you bless all our prayers. In God's almighty name I have prayed.
Amen.
Amen. Amen, and good night, everybody.
Good night. Thank you so much. Thank you, Mr. Beatrice.
Thank you very much for the presentation.
Good night. Good night.
Thank you, Prof. Thank you, Professor George.